6,000 diabetologists in India and abroad. And that is Dr. Raghunathan. I request Dr. Raghunathan to take the podium and deliver the lecture.
Good morning, everybody. Thanks to Dr. Ramesh for the nice introduction. I do not know whether I'm fit for the general introduction by him. He made a comment, that is how many times you listen to a lecture of insulin. He says you will be confused at the end of the lecture. My idea of coming here is to make it the statement wrong, because when you go out of the hall, you should have 100% clear-cut idea on insulin initiation and continuation. Suppose if I am able to achieve this goal, I think I have won the race. With that, I will start my presentation. As usual, my salute to my guru and respects my wife. Then coming to the office practice, actually, before I go, I need a questionnaire for him. How many of you use insulin in your practice? Just raise your hands. Right, okay. What's the percentage of patients on insulin? Suppose if you see 100 patients in your office, how many percentage, approximately how many percent you have insulin on them? 5%. You just, whatever percent you use, just tell 5. 10%. Then, anybody in the other hand? 30%, right? 20%. That is 1/5 of every 1 in 5, right? Okay. And what's the insulin use? Yeah, I just want you to raise your hands. How many of you use basal insulin? Right. How many of you use mixed insulins? No, we are raising for both the hands, but it shows that you are using both mixed and also basal insulin. Right. First choice basal. First choice mixed. What is your first choice? Just raise your hand. If first choice is mixed insulin, raise. Mixed insulin, right. First choice for basal insulin. Okay. Then I think my problem is very simple. My most important question is, if the patient is on insulin, how many of them are to the target? That is, the textbook, on textbook description and also by recommendations, you need to have less than 7 HbA1c if the patient is, whatever may be the mode of thing. If the person is on insulin in type 2 diabetes, how many of your patients have reached a target of less than 7? Who said 80%? Come on, stand up. Just stand me, sir. 80% of your patients on insulin is less than 7 HbA1c. Right? How many? Anybody contradict this statement? Pardon? Have you got your practice audit, sir? Do you audit your practice regularly? Have you got a documentation? I've got documentation for all patients. You audit your practice. But I slightly differ because I practiced for more than around 14 years, and nearly about, because recently I had a practice audit in my hospital, and more than 40% of my patients, they are on insulin, and unfortunately, less than 5% of my patients on insulin are in the target. Less than 5. So 95 patients who are on insulin, they are not the target of 7. This is my hospital statistics. Pardon? I will tell you a story. Yeah, I will tell you a story. One of my friends, one of my students also, he was a student, he was my resource person, he was my friend, now he is no more. I don't want to tell the name. I was traveling with him in a flight to Singapore. And I was sharing the food because I had puliyodare and taisam from my house, and he was totally attracted by the smell of the puliyodare and taisa in the flight. So he came to me, Raghu, he gave me some flavor and Tyson. I just gave him, we were talking. I asked him same question. Boss, how many of your patients are with a target of 7? He said 100%. All my 100% of the patients are having HbA1c of less than 7. Totally I was stunned. He asked me back, Raghu, how many of your patients are HbA1c 7? I said nothing, around 5%. 95% you don't. I do have patients between 7 and 8 in a good range. Between 7 and 8, I have lots of patients, around 55% of patients are between 7 and 8. But 8 and 9, I have a good chunk of patients, around 30 to 40%, which I am not able to do anything. He said, tell me your secret, boss. How do you get less than 7? He said, for first 3 months, I talk to the patient, I treat the patient. Second 3 months, I warn them, no, you should not have HbA1c like that, and you should come perfectly well, all change your things. And the third 3 months, when they come back like this, you change your doctor, which I am not able to continue my treatment, because if you go and tell that I'm with so-and-so and my HbA1c is 8, I cannot tolerate that. Preferably, I do not want to treat you, do not come back. Go to a different doctor. That's the secret of practice where everybody is having less than 7. Right? And I will tell you the Mayo Clinic statistics, 2011. And 2011 Mayo Clinic statistics says, and they are not talking on only on insulin, but in general under diabetic control, more than 60% of their diabetic patients, they are not in target of 7. They are able to achieve only for 40. 40% of the Mayo Clinic, they are in target. 60%. And if you take the 5 parameter, like your weight, HbA1c, at the ABC, that is glucose, B for blood pressure, C for cholesterol, D for our diet and obesity, everything. And they say that they are not able to get the target of for more than 50%. So it's very difficult to get a target. What I'm telling is, most of the time, we start insulin, but they are not on target. It's a practical situation. Why I am insisting this point? Because in type 1, we give insulin for survival. In type 2, we give insulin for quality of life. When we talk on quality of life, definitely we should have a better control. And once the patient is on insulin, definitely we should see to that they reach a target. Suppose if they are not on insulin, if they are not on target, I don't care, because it may not be possible. But once you give, we should give properly insulin, properly insulinize the patient, properly educate the patient to reach the target. What is more important in the situation is patient education. Patient education, which is much more important, reinforcement on the target with the insulin is much more important than anything else. And second, one more question which is not there. How many of you treat type 1 diabetes? Right, only small chunk, right? Because I want to know whether I have to talk the topic or not. Okay. Now, before somebody goes to sleep, I decided my thing that let me give the summary. So with the summary, I talk on my lecture. Almost all patients with type 2 diabetes will eventually fail to respond adequately to oral hypoglycemic drugs, and they will all require insulin therapy at one time or other in their life. This is very, very, very important. In type 2, because the usage of insulin in type 2 increases as the age of the diabetes advances. That is diabetic age. Suppose somebody, and I would like to definitely recall, because my previous lecture, he recalled Rajinikanth, because he said, avoid white. Rajinikanth, இது வந்து avoid white. வெள்ளையா இருக்குது எதுவும் avoid பண்ணணும். That is including sugar, milk, white rice, whatever it is white, and avoid white, and probably you will be much safer. Like that, you can split your diabetic history into 4 halves. That is first 8 years, second 8 years, third 8 years, and fourth 8 years. That is a history of diabetes. And first 8 years comes before the diagnosis of diabetes. That is at the point of diagnosis of diabetes. From the, before that, that is in the phase of IGT and IFG. And second 8 years is our first line of treatment when you are starting the OHA. That is totally 16 years. What is the importance? Because this, I defined diabetes as because there are so many definitions of diabetes, and if somebody I want to give in single word define diabetes. Type 2. I'm talking type 2. I define type 2 as diabetes lipidovascularis. That's all. It gives you a total understanding of type 2 diabetes. That is, in the first half of your type 2, you have the complications due to lipids, which is much more predominant. And second half, second 8 plus 8, 16 years, your vascular complications predominant. So it is diabetes lipidovascularis. So in the first 8 plus 8, 16 years, you will get in the both IGT, IFG, and also first you will have all complications of macrovascular disorder, that is by either infarction or stroke. And third 8 years and fourth 8 year, you will have definitely complication due to, that is third year is very important, you will have onset of retinopathy, and fourth 8 year will be onset of nephropathy. This is how you get a natural history of type 2 diabetes. Here, those patients who have crossed the 16 years, that is 8 plus 8, 16 years, definitely most of them, they need insulin. So if we are having a good practice, probably nearly about 70 to 80% of your patients might need insulin, but they may not accept. May not? That's a problem. If everybody wants to start an insulin, everybody wants to have a good target, but they don't start an insulin, and even if they start an insulin, sometimes they stop or they don't adhere to the schedules of insulin because things are difficult. Now we'll come to the problem. How to manage? That is the regime of bedtime intermediate acting insulin, the combination with the daytime oral therapy. It is acceptable to patients, which is very simple to start, and the results are, they produce a rapid improvement in glycemic control. The advantage of this simple regime of both OHA and the basal insulin, that it can be started safely in general practice and is the most practical way of implementing insulin in the face of the worldwide epidemic of type 2 diabetes. Now, the combined oral and insulin approach, the combination of intermediate acting insulin before bed while continuing the maximum oral drug therapy during the schedule. Now I will ask you a question. How many of you continue OHA when the patient is on insulin? Right. Okay. Then what do you do with the oral drugs? The patient is asked to continue all the drugs of all oral hypoglycemia they are taking currently, and there are some few exceptions for that. That is, if the person is on supramaximal doses of any of the oral drugs reduced to recommended dose, or the person is suffering from any of the gastrointestinal adverse effects of metformin, you can reduce the dose to the limit of toleration. Third, the patient is taking acarbose as a third oral hypoglycemic drug, and it can be stopped because you will have much more adverse effects which outweigh its advantage. Then the reason why you continue, because there are some school of thought that once you start an insulin, you should stop OHA. There are some school of thought. But somebody says that you can continue OHA. But I come to the school that you should continue OHA. That's because even though drugs have failed in the situation that's called secondary failure, they have some hypoglycemic effect. So clinical studies have shown that the sulfonylurea or metformin, if they stop altogether, the need for insulin increases. For each drug, approximately 20 to 30 units of insulin is being needed. So what will happen necessarily, your insulin requirement goes up. Suppose if you stop insulin when you have a self-inflammatory failure, then basically the patient might need more than 60 units of insulin, and almost you have to convert the patient to a basal bolus therapy, which is not needed very usually. Now coming to sulfonylurea failure, because the time in which UKPDS did a survey is around 20 years back, where the definitions are different. Now, for all practical purposes, if the persistent postprandial elevation of more than 200 is to be sulfonylurea failure. And you can see the graph. This is a normal with the 80, 140. That will be the regular graph of GDT. And now in the IGT, probably only the prandial increases. Then after years of OHA, you can see both the fasting and also prandial increases. You can see fasting increases at the same time postprandial. Now, the elevated fasting glucose with a large prandial excretion that happens, suppose the fasting is more than 200. This is the glucotoxicity. This is what books claim as a glucotoxicity. That not only the fasting, but the difference between fasting and postprandial is exceedingly high. Also, you can appreciate usually the normal difference between fasting and postprandial. If you go and have your practice audit, this also I did it. It will be around 70 to 80 milligrams. What I mean is, if somebody has a 120 fasting, probably their postprandial will be less than 200. And if somebody has got 140 fasting, their postprandial will be around some 220, 230. The fasting is 170, it will be around some 250. That's how it goes on. But somebody has got a fasting around 200 and postprandial is around 350. This is a dysfunction of the pancreas that is because of the persistent rise in fasting. This is called glucotoxicity in those situations. Now, if you are using a basal insulin in the situation where when the fasting is higher, then it normalizes the fasting. Once it normalizes the fasting, it secondarily reduces the abnormal function of the pancreas. That is, pancreas is not functioning because of the glucotoxicity. Once the glucotoxicity is reduced, automatically your abnormal postprandial excretion also will come down. You should realize the situation. Then it's preferred whenever the fasting is slowly going high, you have to start on basal insulin. The reason to continue OHA, I already explained to you, if you have stopped abruptly, your need for insulin might be more than 60 units per day. And you have to have aggressive insulin regimes, which may not be acceptable by a common man in India. And dose schedules, monitoring, everything will be difficult. The second thing is, if the person is on thiazolone T a day, as a third drug, still you can continue either in the same dose or a reduced dose, at least for some time till the insulin acts. Just because there are some problems to say, because if T a day is used along with insulin, you have more complications. You have more weight gain, you have everything. So you can have, even still you can have hyperglycemia also. But initially you can continue, or if you want to stop, you can stop T a day also. How much of insulin at what time? For all practical purposes, 10 units of intermediate acting insulin given just before bedtime, and it can be given as late as possible. There's the reason for that. Can somebody tell me? Because everybody told that you are using a basal insulin. When will you give basal insulin? At what time? Yeah, that's at the bedtime or as late as possible. That's because the timing of insulin exerts the maximum action just before dawn. So the time of highest insulin resistance. So if you are giving as late as possible, the peak of insulin action will be at dawn, so that it will be useful to reduce the early morning insulin resistance also. Because I have seen textbooks which advocate the basal insulin to be given around 7 o'clock. Western textbooks, they have given us around 7. But if you give around 7, you will have aggravation of your dawn phenomena, and they can go for hypoglycemia. You give as late as possible, around 10 o'clock or at the time of sleep. And patients who have symptoms of hyperglycemia, then you can have increased dose of insulin to be started as a bedtime dose. It can be usually around 20 to 25, but you have a calculation how much you calculate for starting of initiation of insulin. Yeah, 0.2. Suppose somebody is around some 70 and into 0.2, it will be around some 14 units. They can have 10 to 15 units will be a normal dose, but somebody is overweight, 80 kilos, even 100 kilos, then they might need 20 or 25, because you should understand, as the obesity increases, your insulin resistance also increases. So your requirement of insulin also will increase as the obesity increases. That you should keep it in mind. Which insulin has to be used? And the bedtime insulin is best given as isofen insulin. I always use human isofen insulin. If the patient can afford, they can use glargine. See, isofen insulin, human insulin, 1 unit, it costs around 36 NP to 40 NP. Suppose if you start 10 units, it will be around 4 rupees. And if you start 15 units, it will be around some 6 rupees. That will be the per day expenditure of insulin. If you add to the cost of the syringe, then it will be around add some 2.5 rupees, 7 rupees per day. That amounts to 210 rupees per month. But if you use glargine, definitely it will be 3 to 4 times expensive than your isofen human insulin. And the patient can afford, definitely they can. But there is not much of a difference on your achievement of HbA1c between glargine and isofen. There are enough evidences. If somebody wants evidence, I can show evidence. But the only thing is, the incidence of hypoglycemia might be low, but all the papers are produced only by the companies. Only by the companies. There's no individual paper to say that hypoglycemia. But if at all they say, and if you go back to the paper, I just went and collected nearly about 20, 30 papers on hypoglycemia by percentage of the paper for companies, and all these are all only questionnaire formats. All there are questionnaire formats from the patient, and the capital goes done at the time. Like that only they have done. But if you take the serious hospital admission of hypoglycemia by the drug insulin, the incidence is same for both isofen insulin and also glargine. That's all. Incidence of hospital, if you take in that situation, but non-hospital admissions, only symptomatic, probably glargine score high to some extent. But when you see the graph, the graph is exemplified, and see the, but when you see the number of patients, number of incidences, it will be low. Don't see the graph, see the back of the graph. What it is very important what to tell the patient when you start on insulin. That is, it's very important that you should have how to inject insulin subcutaneously or into the abdomen or into the thigh. It's one important thing. Second is to talk on diet. There is no use in talking on extensive diet for a patient in India. I have some reason for that, I will tell you. But you should know, whenever see, when insulin always goes hand in hand with hypoglycemia. So somebody uses insulin, they should have glucometer. My logic is prescribe insulin with a glucometer. Without glucometer, if you prescribe insulin, probably you are wrong. Probably you will be getting into trouble. Now, even they can go to the court of law, they can sue you. There are so many things because hypoglycemia goes hand in hand with insulin, right? And second thing is, and you should teach them regarding the hypoglycemia also. And why I am advocating to start on basal insulin for a patient, because the incidence of hypoglycemia will be very, very low on initiation of insulin. I'll tell you, I have had enough bad incidences in my early life on practice. I have started them mixed insulin, I have started them regular insulin, and given, because one patient had blood sugar of 430. I felt that his sugar is very high, So I started him on regular insulin, and I gave him 7 units by calculating by the body weight, 7 units 3 times a day. You just have, you come tomorrow. He had one injection of 7 units of regular insulin. He went for hypoglycemia. He was admitted back in the hospital in the night. Only one injection of 7 unit of regular insulin, human regular insulin. Yes, I had enough. Like that, I can quote so many things. Why I'm telling is, please do not start on either mixed insulin or regular insulin on initiation of therapy. On initiation, say I don't say that you should not use it. On initiation, always start on basal insulin, which is much more safer, and incidence of hypoglycemia is very, very low. That's the best way you can start. Second thing is, regarding the diet, we call தொட்டில் பழக்கம் சுடுகாடு மட்டும். This is see, you cannot change your diet style at the age of 50 years or 55 years, because somebody is getting, most of the time we get really in India, the approximate age of onset of majority chunk of the patient is around 50 to 55 years. They are in the peak of earning, they are in the stress, so many things that happen in the office, so many things happen there. At the time they are 50 to 55, they come to you. By the time they have a diet schedule on adult life for more than 30 years. If somebody has lived with his own usual style of a diet for 30 years, and if you want to have behavior modification of a person after 30 years of diet, I think it's very, very, very difficult to modify the diet schedule. எதிர்நீச்சல் போடக்கூடாது. Try not to do changes, modify the diet, but instead you can reduce what is possible in India is only to reduce the calories. You can ask them, have a detailed history and what are all the substances is taking, which is, good morning Prasad, what all the substances is taking, and try to take out, knock out what are the things which is giving extra calories. Suppose somebody is taking 10 coffees a day, definitely you can pull out the coffees, and definitely it will reduce the number of calories. This is how you can show that somebody is taking snacks, somebody that is extra apart from food is taking something, bhaji, vada, pakoda, harabundi, like that. Suppose you take whatever he takes extra, pull out all this extra. Probably it can be replaced by some of the vegetables or salads, whatever possible. Should try to have behavioral modification. Otherwise, it's very, very difficult to have a new life, a new schedule, a new diet history. I don't think it's possible to live like a Western person. It's not possible in India. I think if you achieve it, it's okay, ideological. And what I feel is, always in medicine, you should have 3 things. You should know what is ideal. Right, I accept it. And you should try to aim at what is possible. And you should know what is practical. There are 3 things in medicine, whatever it is, and we should know definitely ideal. What is ideal, you should know. And what is possible, what is practical, we should practice. Now, you can ask me how to titrate the insulin dose with the basal insulin. And 1 unit of basal insulin at night will approximately reduce 10 milligrams of fasting, and depends upon the insulin resistance. So, and you cannot change the dose now and then within 1 day. Suppose if you start insulin today, next day you should not see the blood sugar, change the insulin, not that. Actually, you take the fasting for at least 3 times a week, and take the average as a fasting and change the insulin dose. I will tell you an incident. I come from a family of diabetes, almost all. Good morning, sir. Welcome to Dr. Muruganan. I family of diabetes. Everybody is diabetic in my family, and my now he's 78. He has been a diabetic for so many years, and he developed a CKD, and the doctor asked him to be on insulin. Till the time he never took insulin, but the doctor, nephrologist advised he started taking insulin. First day when he was prescribed insulin, he took the insulin. Within 2 hours, he wanted to test the blood. Yes, no, I want to know how much. Then in the evening, he wanted to test the blood. The next day morning, he wanted to test the blood. and change the dose. I told him it is not possible. And because his sugar never came down, because it was nearly around some 270, he said, it is in the capillary glucose, I want to check in the lab. So simultaneously, you wanted to check in the lab, and this is how people become nervous. You should understand that you cannot check those things like that. We have to wait. And there's nothing wrong. There's no hurry. Nothing will happen. Now I will give you an example. That is, suppose one day a person has got 140, next day is 152, next day 131, and the total is 430. If 23 divided by 3, around 141. The target, we fix it not a single, not 100. It is between 100 and 120, and the difference between 141 and 120 is around 21, and divided by 10, probably he needs an adjustment of 2 units. But the person is having 10 units at bedtime, add 2 units. So we expect the fasting to come back. In general, the dose change is around 10% per week. You cannot, don't suppose you are giving 10 units of insulin, do not jump immediately to 20 units of insulin after 3 days. No. Generally, go slow. Approximately 10% change is more than sufficient, and to reach the target within 3 months, that is more than sufficient. Don't be in a hurry. Diabetic is at any time, it is not an emergency, except a situation in which patient is hospitalized. Generally, the patient needs 30 to 40 units of basal insulin. It is within 3 to 6 months for a fair tolerate of 100 to 120. This is really practical. And what will happen after 2 to 3 months? Because the patient is likely to be on about 30 units of insulin each day and a maximum oral drug therapy. And the measuring HbA1c is very, very important, and which helps to for how much is new level of glycemic control, and a further increase in insulin dose is made according to the HbA1c schedules. Now, once you do HbA1c, how many of you use HbA1c regularly? Right. How do you interpret the HbA1c? Can somebody tell me how do you interpret HbA1c? What's the background? Situations. Somebody is coming with HbA1c 7.3. Another person is coming with HbA1c of 8.7, and third person is coming with the HbA1c of 9.8. And how do you understand the range of HbA1c? Come on, tell me, doctor. I can stand. Mic would I? Bus. Mic.
Fasting insulin level be very, very high if it's between 7 to 8.4, sir. If it is more than 8.4, postprandial will be high, sir.
Yeah, absolutely right. Suppose, yeah, that's you would have read the famous article. Sit down, doctor. That is, if the HbA1c is less than 8.4, it means that in the last 3 months, all along, his prandial blood sugars are in rise. Most of the time, it's prandial blood sugar, less than 8.4. Less than 8.4, he had a continuous prandial glycemia. Yeah. More than 8.4, you should understand that the person had a fasting hyperglycemia followed by prandial. I'll give you an example. Suppose somebody has the HbA1c of around 8, somebody comes HbA1c 8. His fasting would have been 130 and 140, and the postprandial would have been 210 or 200. If somebody comes to you with a HbA1c of 9.5, then his fasting will be around 220, and the postprandial would have been 280, 290. See, this is, you should understand that after 8.4, there is a persistent rise in fasting and also postprandial. And you should not interpret as postprandial, because the rise in postprandial is due to rise in fasting. right? And in less than 8.4 group, the rise was probably the fasting was under reasonable control, postprandial was higher. And you will have understanding that which to be taken care of first. Suppose the person had a persistent prandial glycemia, then you have to target on prandial, right? And we will reach the fasting control by your basal insulin. And suppose after 2 to 3 months, it's generally a reduction of HbA1c of 2% and increase in body weight of several kilos. This is very important. When you start on, and not only on glitazone, the increase in weight, when you start on insulin also, you'll get an increase in weight. It's very important. And an average weight increase will be around 3 to 5 kilos. 3 to 5. If the change is, suppose, if you are starting, a person is on basal insulin, and I have told you that insulin has to have a reduction of 2% HbA1c and a weight increase of around 3 to 5 kilos. If it does not happen, if the changes are not evident, then what are things you suspect? What are the causes? One, lab value might be wrong, right? Okay, then? Pardon? Comorbid condition do what? Pardon? Come on. Compliance is less. What do you mean by compliance in less? Absolutely right. Absolutely right. I'll tell you a story. One lady was there in Neelangare, and she was my relative, and she had a percent hyperglycemia, and I advised her insulin, basal insulin, so it will be okay. After 6 months, I went back to her and then asked her the condition of insulin. Still, it was very bad. And I asked her whether she is taking regular insulin. Yes, she says, I am taking regular insulin. And who is giving insulin? Whether you are taking insulin or somebody is giving. My son is giving insulin. And when your son is coming? He is coming on the weekend, he is coming on Saturday and Sunday. Whenever he comes, he will give insulin. Right? It's called intermittent insulin therapy. So many times people have intermittent insulin therapy, that is insulin compliance, because she is very comfortable. For 5 days, she doesn't get insulin, and she is very happy. And 2 days, her son is happy that he is giving insulin. He doesn't know that his mother is not taking insulin. This is how it's happening. So, now, one should consider the possibility that the patient has not been taking insulin regularly. This is very, very important. That one. Second thing is, if someone who is unfamiliar with the regime of this basal insulin with the OHA, what will happen? They either reduced or stopped one or more of the hypoglycemia. They'll say this is called, like Dr. Santanam always, it's a common word that's called elbow rubbers. Elbow rubbers. They come and unnecessarily interfere with the patient. No. அது எப்படி நீ இன்சுலின் போட்டு மாத்திரை எப்படி சாப்பிடலாம்? 2 சாப்பிட்டா அவனுக்கு ஹைப்போகிளைசமியா வந்துடும், எங்கள் செஞ்சருக்கு வந்துருச்சு, அதனால் 2 செய்யக்கூடாது. டாக்டர் உனக்கு இன்சுலின் ஆரம்பிச்சாரு, மாத்திரை நிறுத்திடணும். So they will stop either one drug or drug which you may not know. So you should always suspect when expected glycemic control is not happening, either they are not taking insulin regularly or they have reduced or stopped the OHA. After about that's a natural history, 6 to 12 months, a further increase. You should always understand any drug has got a tachyphylaxis. And suppose if you have, and if you go to ACCORD study, it's a very, very famous study that when you give both OHA or insulin, whatever mode of treatment of diabetes, as the years go on, your glycemic control deteriorates. Even with increasing dose of OHA or even with increasing dose of insulin also. So deterioration of glycemic control is a natural history of diabetes. So that's because of insulin resistance. Here, what will happen after 6 to 12 months, that there is an increase in insulin dosage according to HbA1c concentration, and finally a daily insulin requirement of around 50 to 60 units, which is higher in the case of obesity, or if you are starting a person for a higher HbA1c, that's a different. insulin resistance. So this is one of the way you can make out that the patient has got some insulin resistance. Then the advantage of combined oral drug and insulin regime is the glycemic control becomes to improve from the day insulin is started, and the titration of insulin dose can be gradual, and therefore it is really relatively safe in an outpatient setting. Then alternative is to stop the oral drugs abruptly, and in this scenario insulin needs to be given at least twice daily, and the dose need to be quickly titrated upward, and it needs to be around 70 to 80 units per day. The requirement of insulin is higher. And actually, sometimes what will happen, your glycemic control may actually deteriorate. When you stop OHA. So insulin alone regime is obviously possible, but requires more patient contact, less user friendly for both doctors and also for patients. And I have witnessed deterioration in glycemic control when both the drugs were withdrawn. This is really my own life experience. And the combined oral drug and insulin treatment is simple, logical, better acceptance, easy to and simple monitoring, easy and dose titration, and less insulin usage and less weight gain. These are all very important advantages. When to stop oral hypoglycemia agent? When somebody has got a frequent daytime hypoglycemia or renal failure, suppose you do watch for a CKD, or somebody has got allergy. And how to manage? Sulfonylurea usage can be reduced or can be ceased, and the sulfonylurea can be changed also. It can be with non-sulfonylurea drugs can be used also. That is, you can do either repaglinate. Repaglinate can be because short-acting non-sulfonylurea drug can be used instead, because only long-acting drugs will produce more hypoglycemia. What will happen to OHA? The dose of insulin needs to go up by an average one. That is when you stop. Already we have made it. When to introduce more complex insulin regimes, when the fasting glucose concentration may be quite acceptable, but HbA1c, I told you, remains significantly elevated. In this situation, a second dose of insulin is given just before breakfast for a short-acting insulin of around 6 to 12 units. This is called advanced basal 1. Advanced basal 1, only for a larger meal or where there is a larger excursion. You can check the blood sugars 6 times a day, fasting, after breakfast, postprandial, and pre-lunch and post-lunch, night before dinner, after dinner. If you check 6 blood sugar values, you know which prandial is more. Which prandial is more, which is the culprit for increase in HbA1c. In that situation, we continue basal insulin and add only a bolus insulin for that particular prandial. So majoritarily for either after somebody takes more afternoon food, somebody takes more dinner, so you can add accordingly 1 shot of short acting, and if needed 2 shots of short acting can be used. And if you want to read more on this subject, read the book on Vivian Fonseca. That's Clinical Diabetes by Vivian Fonseca. He has given more details on that. And that is other patients who are more insulin deficient, because how do you say clinically people are more insulin deficient? Any clinical? Yeah, that's right. One is a lean person, made it, type 2 diabetes, related lean body weight and younger age. It be start on one. Second thing is, somebody has got less subcutaneous tissue. Whenever you see examine a diabetes with a less subcutaneous tissue, probably they are insulinopenic. Or more subcutaneous tissue, so more insulin resistance. In this way also you can go through. And the insulin sparing effects of OHA can be continued with these lean persons also. It is possible. What is the practical solution? There is an inevitable need for insulin therapy in most patients. Is best discussed in the early treatment when the need for insulin therapy is not imminent. So whenever you see the patient the first time itself, when you do education, you have to educate them. If not today, at least after some time, you might need insulin therapy. And this fact has to be re-emphasized every time when they come to the hospital. You may not start on insulin, but the need of insulin has to be re-emphasized. So this is the best way that you will accept insulin in later life. Second thing is, and giving practice of insulin with the saline injections of that's called model. Because instead of giving insulin, you can give some saline, so that I do in my hospital, so that they may not have any hypoglycemia. The intake is only saline. And there are some of the drug companies have the saline samples with them for a pen. You can ask them, they'll give a dummy with the saline, so that they can inject, they can have a trial of injection of insulin is possible, which patient accept. And it will be impossible for the general practitioner to send all the patients requiring insulin to specialists or diabetic clinic. It has to be implemented and monitored in Indian situation. So the regime of giving insulin injection before bed with the maximum oral hypoglycemia for patients with diabetes with secondary failure, it is easy, safe to implement in general practice as a first step of introduction of treatment. Message, the total message of insulin treatment is fix the fasting first. Treat to target next, treat the HbA1c, that is for prandial. Basal is the best. Before I finish, I'll just have few information. When you advise insulin, first time for the patient, they may not know about a pen, because pen has got some differences with the syringe. Syringe is, may not, because it's much easier to teach them with syringe. The pen, what happens, you have to have insulin priming. How many of you know that what is insulin priming? Tell me, what is priming of insulin? Pardon? Yeah, that's right. It's it's correct answer. Because what will happen, when you put the new cartridge of insulin in the pen, when you start, immediately if you say 10 units of insulin, it will not come as 10. So what you should do is, you should turn the thing for at least 1 or 2 units, up to 4 units you can switch on. So you have to have a trial, so that in the insulin should come to the tip of the needle. That's called insulin priming. With 1 unit or 2 units, it should turn, it should come to the tip. Otherwise, it will be empty air. So this will not be waste, because when you give an insulin pen, it may not be having only 300 units. It has more. It has 330 units, approximately 10% extra. That's because whenever you take out the pen, that is, you have to inject the pen and keep it for a few seconds. At minimum of 10 to 15 seconds, you have to keep in the area. You cannot draw the pen immediately. If you keep it for some time, then the insulin wastage will be reduced. Even after that, when you take the pen, you could see that 1 drop of insulin will come out. And you should understand that it is 100 units per 1 ml. 100 units per cartridge contains 100 units per 1 ml. And if you calculate, and 100 units, suppose if 1 ml, that is like a micro drip, 60 drops become 1 ml. So 60 drops become 100 units. Then 1 drop, it's approximately 1 unit. So when you have 1 drop loss, you will have 1 unit loss. So your calculation might go wrong. Calculation might go wrong. It may say that it is 16 units, and it may not be 16, it will be only 15 units, number one. Second thing is wastage of money. So you should, only thing, one is insulin priming. Second thing is, you should have, after injection, you should keep the, in the site, the pen for at least 10 to 15 seconds, so that wastage of insulin may not be there. Second thing is, what is the direction of insulin? Suppose if you have a solid, thick fat, and it can be given 90, that is called 90 degrees, that is right like this. In a thick fat, you can give like that. But when you have a thin person, suppose in the type 1, a thin person, with no subcutaneous fat or a very minimal subcutaneous fat, when you inject 90 degrees like that, it will be intramuscular. The possibility is there. It is not with the pen, but with the syringe, because pen, the current pen is, we have a needle of 31. Needle of 31. We should understand the logic. The bore size and the length of the needle. As the bore size is larger, in any way, this is larger, like a cannula. If you go to take the cannula, bore size is larger, the thin cannula will also be more. Suppose if you take a bore size of 18 or 16, cannula will be larger. If you take a bore size of 22, or if you take a bore size of 26, then the cannula will be smaller. Like that, the length of the needle is inversely proportional to the bore size. So if you have 31 needle, your length of 31 bore size, length will be very small. So less than 1 centimeter, actually half a centimeter. In those situations, even a vertical injection may not go into the muscle. But in the case of a insulin syringe usage, you might, because it is little longer. So you can have, when the subcutaneous tissue is low, you have to inject 45 degrees, not to 90. That's the best advantage of using 90 degrees. And always try to use in the outer aspect of the area or in the abdomen. Right. Thank you. If you have any questions, I will. Yeah, that's the question is he is asking site of insulin for a regular insulin and also for a intermittent acting. See, always when you want to have a regular insulin, it depends upon the job what you are trying to do. Suppose if you are injecting in the abdomen, then you may not walk, and if you inject it, it will take a longer time for absorption. But if you are using in the thigh, the absorption is much faster than the abdomen. That is because you are going to walk. So a regular injection is preferably given in the thigh. And if you are giving intermittent acting insulin, it can be given the abdomen as a depot, so that even if it works late, because it's going to work only after 6 or 7 hours, it is preferably given the abdomen. That's how because it depends on the person what they do. When they walk, absorption will be much more. Suppose if you give in the thigh, a child, type 1, a regular insulin, given the thigh, the absorption will be much better in the thigh than in the abdomen.
So you said one unit of basal insulin reduces 10 milligrams of fasting.
Yes.
That means if you give 10 units of basal insulin, it reduces 100 milligrams of.
Pardon?
You said 1 unit of basal insulin reduces 10 milligrams of fasting blood.
Yeah.
Then 10 grams of. And then if you use
10
milligrams.
Yeah, milligrams.
Then if you use 10 units of basal insulin, will it reduce 100 milligrams?
Yeah, but that is because suppose somebody has, I'm telling you, suppose somebody has 220 as a fasting.
Then only you can start.
Then you are giving 10 units of basal insulin. Yes, then the chance of that is coming back to 100 or 120 is higher, yes, approximately. Yes, but this may not happen if the insulin resistance is higher. It depends upon the insulin resistance. Suppose the person is more insulin resistant, yes, he needs more insulin. Suppose the person is, second thing is, you should understand the insulin resistance varies with the time of the day. Time of the even duration, sometimes more in the morning, sometimes more in the afternoon, sometimes in the night. That's the second thing is, it depends upon the stress of the person. Psychological factors, you need to have time of the day, and depends upon the food what you take. All these things that count. So I'm giving only the initial guess, best initial guess, that approximately 1 unit might give for an initial calculation. Then I told you that after 1 week you take 3 times calculation, 3 basal things to test to be done. Yes, and at that time, if the difference is more, add insulin.
Add 2 units.
Yeah.
So can basal insulin cause hyperglycemia?
Pardon?
Can basal insulin cause hypoglycemia?
Yes, definitely. It is possible.
Can.
So only, but if you give 10 units of insulin, possibility of going for a person with 200 fasting is very low. It may not work rapidly. Glucometers are definitely have to be calibrated every year. And
how do you do that?
That you cannot do that. The company fellow has to ask the company fellow, and they have to come and calibrate. But how to check up? There is a standard solutions available for glucometer. That is standard is 100 milligrams of blood sugar. Okay. So it comes as a ordinary, like a serum. You got a standard. So with that standard, you can do a test.
No. Does every glucometer come with the standard solution?
They don't give it, but you have to buy it.
Oh, so we have to ask for it also.
No, you have to buy it. You can buy. Yeah, oh, okay. You can buy the standard. You buy the standard of 100 and just check it up. And suppose if it does not show 100, you can have some error, at least some 5% error like that. But for 100, if it shows 140, your glucometer is not normal. So you have to ask the company people to come and standardize your blood.
You have to?
Standardize the glucometer.
Oh, so they can do that?
Yes, they can do it.
Definitely. They never do, that's the problem. They never come, they never do. The ideal suggestion would be to change
But
the
only thing
glucometer,
is,
buy a new glucometer
yeah, that's
every
right.
1 year.
See, I'm telling you one thing, very, very frank. What he says, absolutely right. Small doctor, one piece I will tell you. One information. No, I'm telling you. See,
Not very expensive.
when you have a weighing machine, spring scale weighing machine, never you repair. If you repair a spring scale weighing machine, it will never give you the correct weight. Like that, when you have a glucometer showing abnormal, throw away and get a new glucometer. Probably cheapest, you get for 1,000 rupees. There's one thing called one touch simple, which costs only 1,000 rupees. For a doctor, they give for 600. One touch simple. For there's no coding, nothing is there. Just keep it, that's all. That's standard coding, no coding. Just keep it, have it. That's the best way. And if it doesn't work, and you give it back to the company, most of the time they are not replaced, you buy a new one. It's always simple to buy a new one, always better. For second information, your mercury BP manometer should always be calibrated. And I think no doctor has done ever in the world, in India at least. So it has to be calibrated. Any instrument has to be calibrated. And your weighing scale has to be calibrated. BP peppers has to be calibrated. Everything has to be calibrated.
We will permit just one more question, sir. From the rest you can clarify with Raghunathan during lunch hour because our chief guest is already waiting. One more last question, sir.
Excuse me, sir. One female aged around 40 years. She is on oral hypoglycemic drugs. There is no control, so she came for further treatment to me. Her fasting blood glucose is around 320. Postprandial is 340. We started Mixtag. After 4 or 5 days, she no insulin, no hypoglycemia, no any improvement. Later we started plain insulin around 20, 3 times a day. Even then, we could not achieve for further any better thing. What is the best way for this patient?
For the patient, was she obese?
No, medium build. Around 40 years, medium build.
It shows that she has that's a different insulin resistance by itself. That is what you can try is if you want to prove that insulin resistance, you have to give IV insulin. You give insulin drip.
Drip only.
If you give insulin drip, suppose if the sugar comes down by insulin drip, suppose the sugar comes down within 6 hours or 8 hours, suppose from 320 to comes to 70 or 80, even 100, it shows that definitely she has a subcutaneous insulin resistance. That's a problem. And the treatment of the thing is totally different. That we'll discuss separately. It's not outside the board.
Thank
Is
you.
it better to start regular insulin or mixed insulin?
Both are not. I told you 100 times, basal is the best. Basal is the best. Nothing, no regular, no mixed, only basal.
Thank you, Dr. Raghunathan, for a very nice information.